Hi, welcome. My name is Smalley, and I'm here to talk with you today about the rapid ultrasound for shock and hypotension exam using point-of-care ultrasound. The indications for this exam are to identify shock etiology for a patient with undifferentiated hypotension. Just so you're aware, in order to perform this exam, you need to have basic ultrasound skills. As I walk through this exam, I'm not going to review the specific ways that you obtain these images, as there's other lectures for which you can learn how to obtain the views. But we will review how to use different types of exams through this protocol to identify shock in an undifferentiated patient with hypotension. The indications, as I mentioned, are undifferentiated shock, undifferentiated hypotension, or a quick assessment to determine a source of shock. This exam is frequently done in the emergency department or the ICU settings where patients have changes of clinical status or they present unstable. For this exam, you will use all three probes if possible. The phased array probe can be the mainstay for this exam, but if you are a novice scanner and you're used to using other probes for other types of exams, you may feel more comfortable switching from probe to probe. As you practice this exam and become more skilled, you may end up switching directly to the phased array probe for the entire exam. Here are the three probes on your machine that you can utilize for this exam. Again, if you look at the probe on the left, the curvilinear probe looks deep into the abdomen and therefore is a great probe to use to identify the IVC, which is the inferior vena cava, to perform the FAST exam, which is the focused assessment of sonography and trauma, to assess for pulmonology findings or the aorta. The linear probe in the center of the screen can look for things like pneumothorax in the pulmonary exam or DVT. Last but not least, the phased array probe on the right-hand side of the screen can be used for cardiac, FAST, and IVC. But as I mentioned, this exam can be completely performed with the phased array probe if you have very solid point-of-care ultrasound skills. We're going to review the 5 exams that you should perform as part of this protocol. The first exam that you should perform is an exam of the heart. There are many findings that you can see on the heart exam which can help you assess shock. Key points that I'd like to point out for this exam are you should be assessing things such as pericardial effusion, ejection fraction, aortic outflow tract, and right-sided heart strain. The second exam you're going to perform as part of the rush is the inferior vena cava. This is a very simple image of the IVC for which you're just going to want to assess to see if the IVC is collapsible or non-collapsible. The third part of the exam, the M, stands for Morrison's, but as you know from your learning with the FAST exam, this is really an abbreviated FAST exam. There is something called the E-FAST, which is an extended FAST that includes pulmonary images. So in this exam, you're going to want to assess for hemothorax or hemoperitoneum. These can be signs of hemorrhagic shock. The fourth exam you're going to want to perform is an aorta exam. 2 diagnoses that you're looking at for this exam is a AAA or an abdominal aortic aneurysm or an aortic dissection. And last but not least, you'll want to do a quick pulmonary exam as part of this protocol to identify pneumothorax. HiMAP in action. So use this mnemonic as you're standing at the bedside to assess these unstable patients. When you put the HiMAP in action, you're going to want to look at 3 things and think about 3 things that determine shock. You're going to want to assess the pump, which is the heart. You're going to want to assess the tank, which is the IVC, the intra-abdominal spaces, and the intrathoracic spaces where free fluid can collect. And last but not least, you're going to want to look at the pipes, which is the aorta and DVT. There are 4 types of shock, and as you go through this protocol, you can help differentiate what type of shock is present based off of your findings from the pump, the tank, and the pipes. The 4 types of shock that we assess as part of the rush exam are hypovolemic shock, distributive shock, obstructive shock, and cardiogenic shock. This very abbreviated table helps you at the bedside determine what type of shock may be present based off of your ultrasound findings. So let's go through the rush protocol in action. The first exam you're going to perform is the cardiac exam. The 4 recommended views for the cardiac exam are a parasternal long axis, a parasternal short axis, an apical 4, and a subxiphoid. Remember that this is a protocol that needs to be done quickly to assess a patient who's unstable. And so as part of this protocol, you may only obtain 1 or 2 of these views and make decisions to move on to the next exam. Here are some examples of the 4 types of shock and different findings from the heart that can help you assess the type of shock. For example, with a left ejection fraction that's normal or high and a cardiac output that's low, that could be a sign of obstructive shock. And you can use this table to work your way through the protocol. The second thing to assess is the IVC. You're going to want to look at the IVC in long axis. You can perform something called the sniff test, where the patient takes a quick sniff in their nose, just like that. And what you're looking for is to see whether the inferior vena cava is plump or flat. This is a simple yes or no question. If you're doing a much more thorough cardiac exam, you may be doing a lot more assessment of the IVC, but since you are trying to assess a patient who's unstable, you really just want to see if that IVC is greater than 50% or less than 50% when a patient performs a sniff, or collapsible or non-collapsible. Morison's pouch is the 3rd part of the exam, which is an abbreviated portion of the mnemonic to indicate the FAST exam, or the EFAST exam. The FAST exam for the abdominal portion has 3 important parts: the right upper quadrant, the left upper quadrant, and the bladder. You can obtain still images or video images, but remember that this is an assessment of the tank, and so you're looking for areas in the body where free fluid can hide. This is one of the best exams to look for signs of hypovolemic shock in the setting of a patient bleeding out. One of the things you don't want to forget is that hemothorax view. And in the FAST, when you're performing the FAST exam, when you're in that right upper quadrant coronal view in the mid to posterior axillary line, you can slide that probe right up the patient's body into the rib view to look for hemothorax. It's a very quick view, and if you see fluid there, that could be a sign in penetrating trauma or abdominal blunt trauma or undifferentiated trauma or undifferentiated hypotension to determine if that's where fluid is hiding. The 4th view that you're going to want to obtain to perform this protocol correctly is the aorta view. I'm not going to review DVT in this protocol, but you can add on a DVT study if you're concerned that there's a problem with the pipes. The 5 views that are recommended for a complete aorta scan are a proximal, mid, and distal view in the transverse location, in the transverse placement. You can obtain still images of these structures, and you want to measure the aorta from one side to the other side and making sure you're including the walls. Anything greater than 3 centimeters is abnormal. Once you've found the distal view, you'll slide to the bifurcation to look and see if at the bifurcation there's any dilation, and normal for this view is less than 1.5 centimeters. Last but not least, you'll want to obtain the aorta in a sagittal view to get the long axis view. Remember, as I've mentioned with these other exams, you can perform an abbreviated version of this exam based off of the findings that you're obtaining while you're going through this protocol. If a patient's unstable, you may not obtain all 5 of these views if you've gotten information from your cardiac and your IVC and your FAST exam. But it is important that if you were concerned for a primary aortic pathology that you obtain at least a minimum of 2 confirmatory views that demonstrate the pathology. Last but not least, as part of that HiMAP mnemonic that you're using at the bedside in these critical situations, you'll want to look at the lung. We mentioned looking at the lung for hemothorax in the M portion of the mnemonic, and the reason that that is up in the M portion is that is part of the tank, and sometimes blood can hide in the lungs. For this abbreviated exam, you're going to want to look at the lung anterior line to rule out pneumothorax, and this can be a sign of obstructive shock. So let's review HiMAP in action. Again, you're assessing the pump, which is the heart, how it's pumping. Is there free fluid around there? Is there strain? You're going to want to assess the tank where fluid can hide. That's the IVC, the FAST exam, and then hemothorax for the pulmonary exam. And you're going to want to assess the pipes, which is aorta, and then plus or minus, depending on your clinical suspicion, the DVT. You can use this table to help differentiate the type of shock, and as you move through the pump, the tanks, and the pipes, for every piece of information you obtain from your quick bedside ultrasound exam, you can start to rule in or rule out different types of shock. Closing comments about this exam. This is a great exam to do quickly at the bedside for a patient who is unstable and has unstable vital signs consistent with hypotension, and it's an unclear cause. It's great to determine the etiology of shock. While you've probably learned other ways to perform point-of-care ultrasound and you want to make sure that you are thorough with every single type of point-of-care ultrasound exam, this is an example of a protocol where you may use limited views to make a confirmation of a finding or an absence of a finding, and then move on to a second view. I highly recommend that in any of those HiMAP studies, when you're performing them, that if you see an abnormal finding, that you confirm it with a secondary view. As I've mentioned, the rush exam is not a comprehensive assessment of each study. And so many times when we perform the rush exam at the bedside, we may only obtain 2 of the 4 cardiac views that you would obtain if you were doing a full bedside point-of-care cardiac exam, for example. And last but not least, if you practice this protocol, you should, when you are skilled, be able to complete this in 2 to 5 minutes. Remember that this patient is unstable at the bedside and you are the clinician trying to make life-changing decisions for this patient. Ideally, you're going to use the probe to get as much information as you can in a short period of time to guide your care. Thank you very much.